Today I'm going to be talking about ankle replacement. And so if you went around the room, and I'm not going to have people raise hands, most of you probably know someone in your family, probably a lot of people here have had joint replacements. Hip, knee, and shoulder, like Dr. Kowalski talked about, other parts of the body. But what you'd find is if I did the same thing for ankle, it's pretty rare. And there's a couple reasons why it's rare. And we'll start with the first reason, and that's that ankle arthritis is pretty rare. So ankle arthritis or degenerative joint disease, those are interchangeable names, are the name for when the joint wears down. The cartilage lining for the joint, which provides the cushioning as well as the smooth movement of the joint, wears down. And these patients who failed conservative treatment are candidates for ankle replacement. So one of the reasons why it's rare, the actual problem that ankle replacement is a solution for, is because of the joint anatomy, the constraint. It's controversial. No one really knows exactly why it's so darn rare, but it's just very uncommon relative to knee and hip. Most people who have knee and hip arthritis, they ask their doctor, why do I have this? And the answers are aging, weight. In some cases it is from trauma, but in most cases it's just life. Whereas ankles typically, they last, they survive beyond us. Our ankles are fine. And one of those reasons is thought to be the constraint of the joint. It kind of fits together like a puzzle piece. So we've been talking a lot about hips and knees and shoulders so far. Just a quick anatomy lesson. The ankle, we're talking about the joint between the tibia, this bone down here called the talus, and then another bone kind of running along the side like a strut, which is the fibula. And there's a lot of other joints that people think of when they come in with ankle pain that aren't really technically the ankle joint. That's these joints below the ankle. And what I mean by constraint is the inherent stability of the joint. It's not like the shoulder. You can't move your ankle around like this. And that's created by how it kind of fits together like a puzzle. The talus sits directly underneath the tibia, and when it starts to tilt or shift in any way, that's when you start to lead to arthritis. Typically the things that cause it to shift or tilt or wear down are very bad trauma. Like this picture on the left here is what's called a pilon or pylon fracture. That's a fracture of the joint surface of the tibia where it meets the talus, and that can lead to the death of the cartilage and the loss of that smooth, nice surface. Even minor fractures, when they lead to instability or shifting of the joint, can, again, lead to this type of arthritis. And then the picture on the right is something that probably a lot of people here have had, which is an ankle sprain. Now, one bad ankle sprain isn't typically thought to lead to arthritis, although it can. It's usually the patients who have repetitive, frequent ankle sprains, once a month, severe ankle sprains, or even just people who walk around day by day, they wear on flat ground or they catch the edge of a cobblestone, their ankle twists, every day. Those are the people where it can lead to arthritis from the repetitive injury and instability of the joint. So this is kind of the end product. You look at the picture on the left, that's a normal ankle. These are obviously flip-flop ones, the opposite side, but you see what happens on the picture on your right, which is the joint surface wears down. So we know about that. The other thing you can often see, this is a patient who had a fracture. You can see up here, this is a fibula fracture where that fracture didn't heal quite right. You can see how it's thickened compared to the fibula in the normal ankle on the left. And that fracture led to incongruity of the joint where this bone down here, the talus, is shifting up and out, and that leads to the joint wearing down. And the other things you see here are bone loss, like Dr. Kowalski talked about in the shoulder from years and years of having your joint not in the right position. The bone will wear down either on the tibia or the talus side. So there's lots of conservative treatments. NSAIDs means drugs like Aleve or ibuprofen or prescription counterparts of it. There's some very effective but very, very expensive braces that can work very well. This is an example of a brace, and it costs tens of thousands of dollars. It works well. But, for a young patient, and actually these have been used a lot in Army combat veterans who've had severe injuries, where they're making it back alive, where in years past they didn't. We're getting better and better at treating these conservatively, meaning without surgery, and then injections. And that's not really what we're here to talk about today. We're here to talk about the replacement. The big thing is just preventing it in the first place, either by stabilizing the ankle joint or performing a good ankle fracture surgery to prevent it. There's salvage operations, which are ways that we can preserve the joint. things like cleaning up the joint arthroscopically or realigning the joint. This picture on the left, the joint is out of alignment, it's tilted. And with an osteotomy, meaning cutting the bone and wedging and straightening the bone, you can preserve the joint and in many cases make it straight so that a patient, again, like we talked about earlier with Dr. Delos, give that patient 10, 20 years. That's invaluable in order to both give them a better ankle replacement in the future as well as prolong the time for many young patients. Because again, we're talking about, in many cases, very young patients that have ankle arthritis. It comes from bad trauma. And so you can see people in their 30s, 40s, even younger than that with ankle arthritis. And you don't want to jump right to the ankle replacement. And then there's some other salvage operations. And the reason these things exist, you don't really see them much in the knee and the hip and other joints, is because, like we'll talk about, there's a lot of problems with ankle replacement. Things like a distraction arthroplasty, which is literally just pulling the joint open in order to try to stimulate padding or cartilage. And then allograft joint replacements, where you take from a cadaver the joint surfaces and you literally transplant them into the ankle joint. So the gold standard is, or I said was, ankle fusion. And that's literally getting rid of the joint. There's two real, the things I talked about so far are preserving the ankle joint. And here we're talking about either a replacement or a fusion, and that's getting rid of the problem. We're curing the arthritis. So I saw somebody shaking their head when they saw ankle fusion. It's been done for decades and decades. And it's not as bad as it sounds. I definitely would defend it. It can be right for a lot of patients. Because think about it, if you fuse your knee, I mean, you're not going to be able to bend anything from your hip down to your foot. There's one joint between your hip and your foot, and that's the knee. So you wouldn't want to fuse somebody's knee unless you had literally no other options. Whereas in an ankle, there's a lot of other joints, and people can actually walk, run, do a lot with an ankle fusion. It's not ideal. It's definitely not what I think we'll be doing 20 or 30 years down the road, but it really works well, and some of my happiest patients have ankle fusions because they get pain relief. The pain comes from the movement of the joint, the rubbing of the bone on bone, and if you get rid of that and you basically turn it into one bone, they get pain relief. It does give pain relief. Complication rates are low. The biggest complication is non-union, where the bone doesn't fuse, and that usually just means a second surgery. But there are things wrong with it for sure. Number one is we know from long-term studies, people who've had, and this is a lateral view of an ankle, and so there's the ankle joint fused, but then there's all these other joints around it. And then again, we talked about knee a second ago. That's also considered an adjacent joint. And what we find is that a lot of these patients at 10, 20 years later have developed adjacent joint arthritis. And the thought is the ankle fusion is causing that because it's putting more stress on those other joints. Definitely it has less motion than the alternative in ankle replacement, and patients just don't like it. The same reason, you hear fusing your joint, it just doesn't sound good. And a lot of patients they hear it and they just close off their mind to it. And then lastly, we'll talk about the outcomes. It seems like it is a little better than ankle fusion. So ankle replacement, quick history lesson. It's been around just as long as these other joints. It's not like it's a brand new thing, but it was miserable outcomes because the joint really was neglected. It wasn't well understood, and it's just not a common problem. There wasn't as much of a drive to develop the proper components, designs, instrumentations. And just also the surgeons who did them would do, again, like one or two a year, and it would never really get into the way it is with Dr. Ennis, where it's literally like down to a science, and he's doing multiple per week, and it's, really basically like an assembly line. So it was largely abandoned for decades. And in the 90s, there was a resurgence with new designs, but they were still pretty bad. This was the first generation. I'm just going to ignore that because that's a ball and socket version. They're basically probably trying to take a shoulder replacement version and use it for an ankle. So you see how it's neglected. This was a second generation one. All these screws here are not necessarily what you want to see when you have a joint replacement, and that's a sign of why it was so bad. But I saw this particular one up until just the last 5-10 years. I see surgeons still putting it in, but it's really a obsolete version. And we'll explain why in a little bit. So why is ankle replacement so difficult? I've talked about some of the reasons. The big one, in my opinion, is the bone. The talus is a very unforgiving bone. It's mostly covered in cartilage, which is great for motion, but bad for blood supply. It's a small bone. You compare it to a tibia and a femur. These are big, strong, hardy bones. The talus is much less forgiving. And the second thing is deformity, angulation are really common, severe turning in or bone loss in the talus in this joint. And then the same things that cause it to be such a good joint natively, meaning the ones most of us have is so good and it usually survives, are some of the same reasons it leads to problems in that it is so constrained. And then lastly, it's just not a very forgiving soft tissue area. There's not a lot of padding, not a lot of fat, which is actually good for healing, cushioning. So that's the bone we're talking about down here, the talus. And this angulation is another one of those problems, the fact that the foot is not sitting straight underneath the shin bone. So the newer generation, really, there was one that came out about almost 20 years ago, and then there have been several that have followed, are much just better designed. They're actually properly designed for the ankle. And one of these things is, so that's this one that I actually saw quite a bit of, and it was really one of the few options that was available in the 1990s, the quote-unquote second generation. And it required you to fuse the syndesmosis, which is this connection between the fibula and the tibia. And it also made a very big flat cut on the talus, meaning it took a lot of bone off of it. And comparing that just real quick to this version, which is one of the many versions on the market, it's a much more conservative cut. This is the talar component here, and you can see how very little bone is taken off of it. And the newer versions don't require this syndesmosis fusion. The other thing is there's more options for revision now, so people are more willing to do a joint replacement in a younger patient, knowing that they do wear out 15, 20 years down the road. You're not going to be left with nothing there. You're not going to be left with no options. You still have good options for the patient. So these are versions where you can build up further and further your components to be prepared to do revisions like this particular surgery. And then, like I talked about, there's a lot more options on the market, competition, which I think is driving the improvement of ankle replacements. And these are a few of the different versions. There's about 4 to 5 different companies that are making joint replacements in the US, and there's several others in other parts of the country that are similar, and they're all kind of following the same principles. The state of the art is the longest term study of this new third generation is still showing pretty high revision rates, 20 to 30% at 18 years. But significantly better than it was. Pain relief and function in these long-term studies seem to be slightly better than ankle fusion, as well as patient satisfaction, slightly higher. Not like, we're not talking about 2 to 1 type things, we're talking about percentage points, but significant. And we don't really have long-term data on, really the most important thing to me is preventing that adjacent joint arthritis, because you don't want to give a patient another problem with your solution. And we don't really know that yet, but nonetheless, it just conceptually makes sense. If you can preserve ankle motion, you take the stress off those adjacent joints. 300,000, these are all estimates, and they may be over. I think definitely for the ankle, it's an overestimate. We do about, 1 million when you combine knee and total hips per year in the US, and at most, there's probably somewhere in the neighborhood of 20,000 total ankle replacements and about an equivalent number of ankle fusions. And so part of the reason we don't know people who've had them is it's not a big problem, but the other reason is it's just not a great solution at this point. It's definitely making improvement, but I think if you went back and you look at this talk in 10 or 15 years, you'd see that the improvement that's going to be made in ankle replacement is going to be, again, vast. And like I showed those things that people were using in the 1990s, I think we're going to see fundamental redesigns or improvements in ankle replacement over the next 10 to 15 years, but it is still a very good solution for a lot of patients. And thank you.